Hi, everybody. Good afternoon from an overcast Seattle. Today's April 21st, 2020. And many greetings to our friends out there, especially to our near and dear colleagues in Dallas, Texas, Indiana. I see Chicago, many other cities. So welcome, everybody, this afternoon. And my name is Jens Chapman. And we're going to talk about some hopefully interesting and controversial cases. The first half is going to be about a procedure that's near and dear to my heart. And the question is this a forgotten procedure? Is this an antiquated procedure at this point in time? And the second part will be 3 cases that our wonderful fellows have presented. And good news from a procedure standpoint, some of our fellows are downstairs operating with Dr. Hart right now, so things are starting to open up again. But I hope despite all the reopenings, we'll be able to carry on this wonderful online tradition to make bridges across our country. Without much further ado, I'm going to start on the talk part. Alexis, are we okay to go? So in terms of conflicts of interest, I have nothing of relevance to declare. I'm now consulting for Globus, and I have a number of academic conflicts. And am I okay to proceed? I got the thumbs up. So we have a spinning wheel here on the screen, but this is obviously a memorable spring to not remember, hopefully, but we'll be all remembering this for the rest of our days. Between social distancing, Zooming our patients, and a spring with empty parks and beaches. This is certainly an amazing time. And in the middle, we have whole new online friendships, like Izzy Lieberman doing his Godfather impression, watching us on one of our great conferences. This is about the cervical spine, and unfortunately it's quite prone towards degeneration, and this degeneration can take place anteriorly and posteriorly and laterally, and obviously this is something that is quite disabling, and even in this time where we've had a lot of issues in terms of OR access, this is one procedure category that we've had more permission from hospital administrators and the God Squad, as I call it, to get in. So I'm briefly going to talk about the clinical problem of myelopathy. And a very small, brief outlook from a surgeon's perspective, and very briefly compare traditional surgical procedures with the main focus, which is laminoplasty. And again, this kind of a cervical spine is a common problem. It's spondylotic, it's kind of collapsing, it's bending forwards. There's some degree of spinal cord compression, some degree of foraminal compromise, and obviously the crux of the matter is what kind of life does the patient lead, what kind of expectations do they have, and what are the actual neurologic manifestations. And I always find it, beyond all the treatments that are available, interesting to kind of separate surgeons into 5 basic categories. Those are the people who focally try to pinpoint something out. Then there's the more annuity-based surgeon who kind of looks at one level at 1 year and then another level at another year. And then there are the rigid people who want to just turn everything in a mobile spine into a rigid log. And then there are the globalists who want to solve everything right away. And again, thanks to a number of procedures, and laminoplasty is obviously one of those, there's something where you can kind of try to maintain mobility while solving the neurologic and hopefully pain and functional problems for the patient. So obviously we want to always fulfill the 3 key requirements, which is to be effective, safe, and preserve function for patients, and mobility in a spine hopefully is one of those. And I'm going to show some cases along that line that went well and some that didn't go so well. So again, this is a lengthy text diatribe to accompany this patient's conundrum, but without reading it, basically this is a patient who has a mixture of myelopathy and radiculopathy problems. And again, the case for a laminoplasty would be that in this particular patient, a comprehensive subaxial decompression can be obtained, and the motion can somewhat be maintained. But there's some questions, and obviously you want to make sure the patient does not have inflammatory disease, there should not be a fixed kyphosis, and there should not be instability present. And this is what puts such a patient into a greater risk and a great deal of controversy. And talking about that, one of the biggest breakthroughs in terms of the assessment of the cervical spine structure is probably the identification, thanks to the ISSG, of the inclination angle of T1 and the overall alignment of the cervical spine relative to the torso. So just a quick outlook, but this is something that with modern imaging techniques really becomes far more apparent to us. And we can kind of at once and for all now understand how the cervical spine actually fits to the rest of the patient between cranium and pelvis. And stability is still something that we have to have a flexion X-ray available to understand the connective tissue as well as the muscle tone of these patients and understand what's actually going on in these patients. So alignment, instability, translational, and sagittal rotations are still conditios sine qua non, things that we absolutely need to have to understand what's actually going on with a patient, and again, understand arthritis patterns and instability patterns relative to joint destruction and connective tissue diseases. So this kind of a kyphosis, as you see in this particular patient below, is a very important and very distinct differentiation to make, as well as the reducibility of this in terms of can this slot back to a more normal position. Now, one thing that I think all of us should really agree on, and I think that, and I'm going to challenge all my great colleagues around the country here, we should really become, I think, far more vocal about the diagnosis of myelopathy. There's not a single test that identifies this, but it's a pervasive problem, and without over-calling it, raising at least awareness should be a big deal in medical schools, wherever we have medical trainees around us. It's disappointing that many neurologists actually don't even pick up on this, so I think this is upon us to take the helm. Worsening is still not very well understood because the majority of the literature comes mainly from China and from Japan. And again, roughly 1/3 of patients probably get worse over about a 3-year period. But that's, again, a very selective and maybe culturally influenced kind of a perspective. So longer-term natural course history studies for other cultural circles have still not really made it. And again, one of the classic things, and again, this is a construct I would not use nowadays, is a multi-level anterior decompression and fusion. And again, the main problem there, as we'll see in some of the cases later, is the carrying capacity of the vertebral bodies in front that have to counteract the weight of our head and an inclination towards flexion and achieve a solid healing result. I achieved this in this particular patient, again, a construct I would not use nowadays anymore, but osteoporosis and lack of posterior muscle tone can be very solid adversaries towards a good healing result. And front-back procedures are obviously a biomechanically sensible solution. Again, this is a construct I would not use nowadays. This is from my history textbooks, but it's also the most invasive option with significant possible counter effects. So posterior options are obviously a problem because you want to have a lordotic spine ideally, and in those cases, there are a number of options, but basically a laminectomy and fusion or a laminoplasty were classic options. I grew up in an era where there were many neurosurgeons who told me I can do a simple laminectomy, and I probably think that they do have a role in certain patients. It's inexpensive, it's time-honored, and again, you want to stay out of the facet joints. That was the main thing. You want to not have it done in a hypermobile patient. So there are a couple of very good points of wisdom there. And again, in some hands, I guess it does work. The problems are instability, deformity, and the famous pseudomembrane that can form posteriorly in a tension band section. So this is a case that I actually treated, and I'm not going to go into that too much. It was a 69-year-old patient with a cervical laminectomy, and he came with a pretty disabling array of neck pain and neurologic problems, and he had developed the classic swan neck, that kind of a double-angled hyperkyphosis, hyperlordosis conundrum. I'm sure this is something that all of you still see in your practices. Again, this is a progressive disorder and has to be dealt with in a very invasive anterior and posterior surgery. Dan Rue identified, I think as the first one, the post-laminectomy instability and also the membrane formation posteriorly, where basically a pseudomembrane forms that then constricts the spinal cord, even in presence of a lordotic spine. So this is one of those things that, again, happens. We still don't know how often it happens. And again, Gui identified a century ago, just about, in the last century, about 1/3 of patients are going to kyphosis and about 1/4 of patients are going to some instability. But not a very high number of reoperations was identified at the time, leaving the laminectomy for the posterior cervical spine decompression still in kind of a gray zone. It's kind of an antiquated procedure now, and maybe we can talk about that later, but the incidences, depending upon where you apply the parameters, relatively high. I do know that revision surgeries are far more arduous and difficult procedure to do. So this is, again, something that's probably fallen out of favor largely, but it may have a role. And again, Alex Vaccaro and Todd Albert identified, again, in their larger review, that this is still something that may have a very narrow role, but is probably far narrower than what originally was done. Stretching over to the posterior fusion, that's obviously, if you have a lordotic spine, a very rigid, very definitive form of more or less destabilizing and decompressing neural elements, both centrally and foraminally, and can be a very effective way to fuse patients. Over 95% of patients will have an effective fusion. Now, I'm going to talk about a study that I was privileged to be part of. It was a multi-center study, and we looked at myelopathy. And without going into too much detail of this, because the main point will be coming up later, a decompression infusion, whether done anteriorly or posteriorly, does provide an about 2.5-point improvement of a Neuric scale and provides about 5+ points of MGOA improvement. That's with all comers, and it does decrease in a statistically significant factor, the NDI. And the question of anterior versus posterior is very difficult to do. This study was a prospective observational study. Basically, all patients on both anterior and posterior procedures did improve, but anterior procedures had far less invasiveness and far less blood loss, but they were more limited in terms of the levels, the number of levels decompressible. Now enter the topic of laminoplasty. This is, again, a procedure that allows us to decompress the spinal cord from posterior, and it's a multi-level procedure, so it has the advantages of a multi-level decompression, such as a fusion. It can very effectively widen the spinal canal, and it can allow for foraminal decompression also. So this is a case of a laminoplasty, and again, if you look at how many patients have been treated overall, basically in a peer-reviewed systematic review from a couple of years ago, the studies in principle are pretty favorable. There were a couple of problems identified. Now I'm going to switch back to the AO study. In our AO study, when we compared posterior fusions to laminoplasties, we found the same neurologic improvement, but we found far lower blood loss, far shorter surgery, and far smaller numbers of overall complications. So just from all things being equal perspectives, a laminoplasty actually stood out as a very potent and reasonable option for appropriately selected patients to fusions. Which brings me to the question of why wouldn't we do more laminoplasties? Because in our study, where every surgeon could do everything that they wanted to do, probably about 1/10 of the posterior procedures were done through a laminoplasty. 9 out of 10 surgeries were done with a fusion. Now, of course, and I want to repeat this theme, a laminoplasty is not a cure-all for cervical spondylotic myelopathy. There's so many different variables in question. And one of the original conditions that this procedure was themed after, the condition of an OPLL, ossification of the posterior longitudinal ligament, is probably not a good indication anymore because it may actually continue to grow. Another problem that I've identified in laminoplasty is that everybody comes up with their own procedures. Literally every prefectura in Japan has its own variant with sutures, non-rigid fixation, interposition grafts, no interposition grafts, etc. If you condense it down, there were 2 main procedures, the French door and then the open door procedure, which basically originated this. And both procedures allow a very wide decompression of the spinal cord. One is aesthetically more pleasing, the French door. The other one, the open door, at least in North America, has become the runaway favorite because it's actually somewhat easier. Without going into too much detail on this experienced group of surgeons, this is again a open door procedure and a French door procedure, and basically there's an overall 35% improvement of the canal size with both techniques. Many of us nowadays here in North America use interposition grafts, usually at every level. There's some surgeons who skip some levels. There's some surgeons who say you can take the C3 spinous process off. But in principle, a very reasonable good practice is to put some form of an interposition spacer or biologic graft in there to restore a very nice spinal canal and to only crack the other side so that you basically have a green stick kind of a fracture to allow for healing on the opposite side. It's a very controlled procedure. Without an interposition spacer or graft, things like this can happen where you can see a sudden kind of reclosure of the graft, which is well documented in the Japanese literature, but which is almost unheard of in North America. Segmental fixation has been something that has been really pioneered probably more in North America than in the Far East. And again, the goal here is to allow for early painless range of motion while allowing a healing of the hinged part as well as of the interposition spacer, if it's a biologic one, to occur. And this is, again, a classic picture where we have a green stick on one side, a laminotomy on the other side, and we've carefully opened up the spinal canal. We've done foraminotomies where needed. We put interposition spacers. Here are shaped allografts in, and then we affix a small plate to each segment to allow for this graft to heal in with the highest possible likelihood. I don't have a lot of long-term images of patients because honestly, as I'll say later in my results disclosures, most of them actually have done very well and returned to normal life. But these allografts actually heal in very nice, and you can see that the hinged part has reasonably ossified as well. So these are some other patients with more long-term outcomes. And again, they actually heal in quite beautifully. So you can restore a pretty normal-looking spinal canal again. And the goal is to have the spinal cord, which is a hydraulic column, fall away from the anterior column so that you have a normal physiologic CSF column reestablish itself, such as seen in this OPLL patient when I still did laminoplasties for OPLL. And again, the range of motion in this particular patient was actually quite good with a very nice clinical outcome. To reiterate, there are clear-cut contraindications for laminoplasties. A clear contraindication is a preoperative kyphosis or instability, or if you have posterior element insufficiencies. It goes without question that these are not good laminoplasty patients because otherwise we're just duplicating a laminectomy. Now, if we look at a couple of factors that have been classic concerns about laminoplasties, if we look at stability, actually the stability of a laminoplasty, if you preserve the posterior ligamentous complex, is actually literally comparable to a normal cervical spine. So you're not compromising anything, and that's in big opposition to laminectomies. Major complications, what are those? Neurologic deteriorations, very rare. Radiculopathies, we'll talk about that. Loss of range of motion, kyphosis, and neck pain and instability are the big factors. In my own practice, this is a very subjective statement. What I see as a problem is when poor surgical technique was paired with poor decision-making. And such as in this patient who came to us, there's nothing else you could do but basically revise this patient. One thing that I've seen occasionally is progressive kyphosis. This is something we're all worried about. And again, those are patients that are probably, a priori, again, not good candidates, such as the patient on the left side, where there's a clear-cut progression of kyphosis seen on the right-hand side. But in the big picture, if we look at patients who have a loss of alignment, there's a clear-cut kind of a tendency to fall forwards a little bit in some patients. As an elderly patient of mine, if I summarize the literature, about 12 to 20% of the overall lordosis can be lost with a laminoplasty. My personal suspicion is that this probably has more to do with muscle activation posteriorly and a tendency to want to fall forwards. Many patients have a straight neck, actually, and that's, again, very anecdotal, will go backwards. But this is another patient of mine who drifted into some kyphosis over time. She actually was quite happy with the surgery. So this is my decision-making. This is a patient, again, I showed this individual before who had a really significant kyphosis beforehand, and a very poorly done laminoplasty was carried out with kind of a hybrid of a French door and no interposition grafts were used. So I'm not sure what the goal here was, but this was clearly a patient who was quite miserable and required a major anterior-posterior fusion. Now, what about the question of decreased range of motion? So mainly extension is probably the one feature that some doctors in Japan have mainly identified as being a problem. You lose probably about 5 to 10 degrees of full terminal extension if you look at this here. Dan Rue, for instance, suggested just take the C3 spinous process off, and I know Dr. Ahn has published on that, and Dr. Sasso. I'd be curious to hear their thoughts on that later. So you lose a little bit of terminal extension, but for the most part, the arc of motion is actually pretty similar if you look at before and after patients. Some patients will autofuse, and that's usually a reflection of an inflammatory underlying disease where the spondylotic process will basically lead to a progressive ankylosis, usually a fibrous ankylosis of their neck, such as seen in this practicing older surgeon who is a very well-known pediatric surgeon who absolutely did not want to have a fusion and actually did very well and was able to practice with his laminoplasty. So autofusion is somewhat technique dependent also, and again, I do personally think that the refinement of technique and segmental stability with no collar afterwards will help in that. What about neurologic deterioration? Again, this is something that is very rare. This is a patient who had a spinal cord injury, and this patient with a central cord syndrome had a laminoplasty done. Nowadays, I'm not sure I would do this procedure, but back then I thought this was a good idea. This patient actually did quite well. So even when you've had a neurologic injury, laminoplasties are still being done around the world for relatively stable necks with a central cord syndrome. Again, a point of discussion perhaps for later. Now, the issue of a radiculopathy after laminoplasty is not a trivial one. The recorded literature revolves around 5+% of patients having mainly a C5 palsy. Here again, technique is a very big deal. Basically, one of the big factors is probably that the C5 root can be trapped in the foramen and can then be subject to a very significant traction phenomenon. Andrew Jack and Dan Rue and others did a very nice, there's a conflict of interest declaration coming here, Global Spine Journal, systematic review very recently, and they identified traction probably being the leading cause of the problem. A technical issue is if you place your cut a little bit too lateral into the facet joint, you're probably creating more of a pulling phenomenon on the cord where it pulls away from the root. So making your cut on the trough between the direct connection of the lamina to the facet joint is something that has been identified in the Japanese literature as being important. And also not angling the graft or the hinge side more than 60 degrees. So being kind of content with a nice spacer placement, roughly maybe 10 millimeters max, but not angling the hinged part more than 60 degrees. 60 degrees is a big deal. So this is, again, a case in question. And again, this is a case of mine. Full disclosure, I had a complication with a radiculopathy afterwards. I did not have the pre-shaped allografts in those days. I used fibula. And you can see how my hinge popped open because I went past 60 degrees on the hinge side, and the hinge actually popped inwards. So that was an iatrogenic complication. So this is, again, the case in question. This was a physician, and this was many years ago, and I did not have a fixed instrument set. I used cranio-maxillofacial plates in those days, and we did a very nice decompression. He had a beautiful resolution of his myelopathy, but he had more radiculopathy afterwards, and that led me towards basically revising him for an anterior-posterior fusion. So that was not the intent, but that was a learning point, and I disclosed that to the patient, obviously, with disappointment. Again, I can't overemphasize, and I've said it for 3 times now, if you have a kyphotic neck or an unstable neck, it's probably not a good idea. Scratch it. It's not a good idea to do a laminoplasty. But in principle, I looked up at around 210 patients. I've never published it because I changed health systems 5 years ago. But I know of 3 patients that had a revision surgery, and 1 patient had a postoperative kyphosis. I showed you that patient before who stayed with that and did not want a repeat surgery. But on the top right is a typical outcome. Patients are actually quite happy and return to normal or near normal work. And again, does it last? This is a case of a 60-year-old friend of mine. He's a vascular surgeon. I did a laminoplasty on him in 2006 because he was very worried about working. He's a traditional vascular surgeon with his neck flipped forwards. This is not a picture of him. This is a stock photo, by the way, but these are his long-term images. And they basically show him, this was at 8 years afterwards on the left, and on the right-hand side you can see a recent one. This is about 13 years out. What strikingly is different is that he has spondylotic disease that basically ossified over time. So he basically self-ankylosed between C4 and C7. Neurologically, he was very happy. He had a very nice maintained decompression of his cord. He has some beginning radicular symptoms, which we're treating non-surgically now, but we may have to look at him in greater detail, and we may have to do firminotomies after all. So coming to a close, again, one key point I hope to rally everybody around as a point of common agreement is that we should identify and should be vocal advocates for early detection of myelopathy. Just reflecting on the last month here, it's really amazing how many patients in the present day of age still come in with pretty flagrant myelopathy, which is a painless disorder usually, and which has just not been really treated. A timely right surgery is a potentially curative procedure, and I do think laminoplasty has and maintains a comprehensive and safe treatment option with excellent results. The burden of disease should not be so bad that patients decompensate, which makes any procedure far harder. So laminoplasty, and in my book with a segmental fixation and allografts, allows for early range of motion, a secure arch expansion without need on a collar. It's a simple concept, and it does prevent recurrent closure. It's a biologic spacer in my hands that's unsurpassed over anything else. And this is a totally unproven point. I think that the fear that was raised in the Japanese literature of about 30% of neck pain with this kind of a construct is just not something that I have seen, but I have no proof for this. The downside is it's a relatively expensive procedure. It is fickle. You have to be very precise with everything. And more recently, the reimbursement for these procedures has dropped substantially. And a failure rate of about 5% is still what I tell patients to anticipate. With this, I'll close this lecture part and switch to some great case presentations. And obviously, I hope that we use the various online options. Tomorrow morning, we have at 7 a.m. our Spine Technology Education Discovery Discussion Debate Forum. And Friday, the University of Utah will host a great journal club, curated and hosted again by Rick Geyer and our great friends at TBI. With this, I'll close and maybe invite for some questions from our faculty. So thank you.
Hey, Jens, I can ask a question if that's okay.
Go ahead.
Okay, number one, I have never heard the term prefecture used like you use it. So I had to Google what it meant. So excellent use of a word, prefecture. The second actually question, which always troubles me, is the concept of we throw around the term myelopathy. And I know everybody on this faculty has traveled around the world, and depending on what country you go to, what we consider a myelopathy in the US doesn't even bubble to the surface in some of the countries that we travel to. How do you how does it factor into your decision-making process for a big surgery? I mean, you can say it's a big surgery or not. The extent of myelopathy. What do you consider clinical myelopathy as opposed to a couple abnormal reflexes versus something that is a decision maker in whether to undergo, a significant open surgery?
Great question. Thank you. So, first of all, it's important what kind of a patient, what kind of a health, what kind of life experiences are we talking about and talking to? What is the rate of progression is the second big question. If this is a functionally disabled patient who is highly quadriparetic, spastic in a wheelchair with a very limited life expectancy, it's probably a very different outlook from a young surgical colleague who's at the beginning of his career and walking with a broad-based gait. In terms of a improvement, I think all of us can actually really do a big deal by putting the NURIC scale and the MJOA into our auto spell or smart text phrases of our EMRs and use those routinely when we see a patient with suspicion or manifest myelopathy. That allows for better tracking and also results objectivation. Michael Failings deserves a lot of credit for having actually added to the literature with his great AO international studies and counted to your point, actually NURIC and MJOA have a pretty good international consistency. In terms of surgery, of course, to the present date, the sooner we pick up myelopathy, the better. Now, in frank terms, do we have to operate on a NURIC 1 patient? Probably not. Informing the patient, identifying what is their sport or their recreational exposure, their work exposure is a big deal. At least tracking it, identifying it, maybe doing some activity modifications is a big deal. Counter that with a NURIC 3 patient where there's clear gait instability present, where there's uncertainty in walking up and down the stairs. That is something where probably a more aggressive surgical decision-making is probably in the patient's best interest. The gray zone are still the NURIC 2 patients with some hand dysfunction, some leg dysfunction, and that's, again, a very intense and a deliberate decision-making process between the patient and the physician. So with that, I'll end, but thank you.
Jens, that was a great talk. And when Jack joined us at TBI, we used to do a lot of laminoplasties, and then we started using plates, and the patients did much better. When we started to get bigger and our younger partners came in, there were a lot of anterior posterior fusions. And in patients that should have had, we thought were candidates for laminoplasty. Could you just give everybody a feel for understanding the selection criteria for doing the laminoplasty? What percent of myelopathy patients you do laminoplasties, and what percent you'll do the anterior posterior or anterior alone?
So I'm going to poll our fellows. So just that you have a view of the room, we have, at this point in time, 7 fellows and Alexis and Lee sitting here. So what percentage of my myelopathy patients get a laminoplasty? Rough estimate, Eric.
Maybe 1/10 to 1/20.
He says in clinical reality, 1 in 10, maybe less. Ben, estimate?
I was going to say 1 in 20.
1 in 20?
I'll say 1%.
Very few. So I'm actually very similar to the AO study, where about 1/10 of the posterior procedures were done with a laminoplasty. The contraindications in my clinical practice are profound. I get a lot of severe myelopathy patients with a rigid kyphosis, multiple previous neck surgeries that failed, things like that, inflammatory diseases. So the clinical reality is a very different one. The question is, without advocating for over-operating, earlier laminoplasties probably in some patients, and this is what the case discussions here will revolve around a little bit, might help avoid having to do big fusion surgeries, may be treatable with a laminoplasty plus a foraminotomy where needed. So that's the whole point of this discussion. But thank you for your comment.
Jens, how much lordosis do you require? The flip side being, how much neutral alignment or kyphosis will you accept and still indicate a laminoplasty?
This is something that, again, John Heller and Dan Rue specifically taught me, and that is if a patient has a straight neck and good collagen, good connective tissues, good muscle tone, good recruitment, I'll consider a laminoplasty. Ideally, they have a stable lordotic neck, but if they have with that infolding of the ligamentum flavum, if it's a severely spondylotic neck or, again, an inflammatory arthropathy, or if they have some form of a difficult neurologic condition like Parkinson's or so, those are clear contraindications. So they're way more, at least in my practice here, contraindications than clear good indications. But when they arise, I must admit I do advocate in favor of a laminoplasty.
Jens, when you're evaluating patients, are you looking at the global sagittal alignment, and do you have an upper or a lower limit for when you would accept a laminoplasty versus a posterior reconstruction if you've got someone with a positive sagittal balance?
Great, insightful questions. So my answer in one sense is not enough. We're still looking for a global spinal imaging system here. We still haven't gotten it. We're still working hard on getting it. If somebody has an accentuated thoracic kyphosis, a laminoplasty is probably not a great idea because the patient's inherent tendency may be to fall forward. So again, if there's a steep T1 inclination angle, 30 degrees or higher certainly becomes a problem, then a laminoplasty is, again, not a good idea. It's a less invasive decompression. It does not create the very bad swan necks that a posterior laminectomy alone does, but it's probably a suboptimal choice. Great question. Thank you.
So yeah, Mr. Howard, can you hear me? So I really enjoy your lecture, and I think I agree with most of the things you said. You know, I've been doing laminoplasty since 1993. I learned it from actually a Japanese postdoctoral fellow. So I'm really, laminoplasty is one of my favorite operations I do. But I do have an indication, okay? So I just like I do have a specific indication for laminar framinotomy, I have patients that I prefer to do laminoplasty in this setting. So the patients obviously have to have a neutral to lordotic, as you said. But in addition to that, if they have a myeloradiculopathy, I like to have the radicular on one side, it's lateral. So technically, you can do framinotomy bilaterally, but it just becomes too technical to do a framinotomy on the hinge side, and you can break the hinge and all that. And the patient should not have significant neck pain. Once again, everybody has a neck pain, but if they have a severe neck pain as a part of it, not that common, but some people do, there is some issue about laminoplasty actually producing neck pain, so I don't want to have a preoperative neck pain. And then everything else you talked about, instability and deformity and all that. So, and then I just want to say one thing about the C5 palsy or radiculopathy, because really it's more common than you think, because it doesn't have to be C5. Whether you do a laminectomy infusion or laminoplasty, you really want to look at that foramen very carefully, either by MR or sometimes CT. And those, if you have already preoperative foraminal stenosis, those are the people I think have higher incidence of postoperative complication. So I do obviously intraoperative monitoring, but sometimes I do a foraminotomy prophylactically to decrease the incidence of C5 palsy. Finally, the technique of laminoplasty have changed over the years. I mean, first 10 years, I used to do C3 to C7, like all the pictures you showed. But many cases, actually at C6-7, the core compression is not that severe. So you can actually do a little dome, because what you want to do is preserve the C7 and C2 spinous process if possible. You don't want to muck around too much with the laminoplasty. So last 10 years, I don't think I have done a lot of C7. My usual construct is C3 to C6. If there's a little compression, I do a dome, take the edge, the top portion of C7 a little bit to undercut. That's enough. And in terms of fixation, yes, I start out with allograft, without fixation. But when fixation came along, Medtronic, then actually my current construct is no bone graft, just a plate, rigid plate, And actually, if you make it rigid enough, the hinge side heals, so you don't need to put the allograft on the opening side. You're using it, that's fine, but I'm just saying that you save time, and I haven't had a problem with really collapse. Obviously, laminoplasty is a very technical procedure, so you have to do it very carefully. It's a slight different technique I'm talking about, but I really enjoy your lecture.
Thank you for your nice comments, and every point that you made is an excellent one that I fully agree with. So just to take home one important message, if there's a radiculopathy, it's preferable to do the hinged open side, so the open door side on the side of the foraminotomy. The other side is actually quite difficult to get into, and I couldn't agree more. A question to you, Howard, if I may ask one counter question. Is there a difference of neck pain and neck pain? Is there a neurologic or myelopathy, stenosis type of a neck pain versus a myofascial neck pain? Could you elaborate on that? Because I think that the literature does not, and the NDI does not differentiate that. Thank you.
Yeah, that's a very good question. I've been dealing with patients with neck pain in the cervical spine for many years. And there are more than 2 types. There are like 4 types. Number one is, myofascial pain that is not that bad, okay? But they have a little bit of, pain with the stretching of the muscle. But another thing is spondylosis pain, obviously. That's a little more significant, but it's not, that bad. When it becomes a severe neck pain, I actually published on the C3 and C4 radiculopathy, because they have sort of C3 and C4, and guess what? We say, ipsilateral neck pain to the trapezius muscle. It's just a neck pain. No, it's a C4 radicular pain. So a lot of people with neck pain associated with spondylosis has either C3, C3 is kind of uncommon, but C4 is very common actually. So if you have a patient that is in the C4 distribution, I do foraminotomy to relieve their neck pain. And then if you actually do a laminectomy infusion, you can decrease the foramen at C4, and they have a severe postoperative neck pain. So I just want to say about the neck pain due to C4. Finally, it's really, as you mentioned, a lot of this postoperative neck pain, it has to do with the muscle closure. So posterior neck, whether you do a laminoplasty or laminectomy infusion, the closure, how Dan Root does like 20 layers of closure, crazy, but you have to do real good closure approximation of all this muscle back to the, so the closure is very, very, very important. So if you don't do a good closure, there's a little fascia dehiscence that gets into severe neck pain, so that's a big issue. So I think that we need to continue to study this patient with different type of neck pain.
Great. That's a whole textbook right there. Fantastic wisdom. Shall we go for some cases? Ben, are you ready to present yours? Oh, do you have to load it on there? Lincoln, are you ready to jump? Lincoln Jimenez?
Jens, a quick question from Dr. Boa. Do you let bone mineral density influence your decision?
For a great question. For laminoplasties, not really. That's a great point. I've not seen that to be a big problem. Presence of a inflammatory arthropathy in RA would be a clear contraindication, because they're leaving a inflamed joint onwards and percolating onwards is a problem.
Thank you.
Lincoln, are you loaded up? All right. Lincoln Jimenez.
Right, so good evening, everyone. My name is Lincoln Jimenez, one of the 5 spine fellows here. Today I'm going to present one case of a patient, a female patient, that 54-year-old female who complains has been present for about 6 to 12 months. And she presented initially with neck and shoulder pain, as well as some numbness of both arms, which by the way, would worsen by extension of the neck. On top of that, she also had some progressive issues of ambulation. And by the time she came to us, she had some assisted ambulation. Pretty much she was needing a walker and or some personal assistance to mobilize. That condition was actually present for about more than a month, 1 or 2 months. Her NURIC at the time of a presentation was a 4. Some of the medical conditions were high blood pressure, diabetes, among other things, some cardiac issues. The past surgical history was based on cervical laminectomy and lumbar spine surgery ×2. And the physical examination was positive for muscle wasting, particularly the upper extremities, and 4/5 strength throughout. She also had some reflection. And imaging-wise, this is what we found. We found an MRI with slightly loss of lordosis of the cervical spine with stenosis secondary to degenerative disc disease at C3-4 and C5-6. So at this time, of course, we also had a CT scan that also helps us a little bit on the understanding of the spinal canal. We found that she also had some spinal canal stenosis, congenital most likely. And this was pretty much relative or borderline stenosis. So based on that, and I'm not sure if we have time to ask for these questions, but we ask ourselves this question is, first of all, what's the approach we're going to use for this patient? Whether it is going to be an ACDF, plus or minus corpectomy, an ADR, either we do a hybrid or laminectomy plus fusion or laminoplasty, or at the end, an anterior-posterior stage procedure. So,
Can you talk about flexion? We don't have the X-rays
Okay.
right now. Flexion extension X-rays were stable, right?
So the flexion extension X-rays absolutely were stable. There was no issues about that.
So quick question, you asked about how high to elevate a laminoplasty, and then I want to hear your thoughts on this case. I usually try to get about 6 to 10 millimeter grafts, and I still like the grafts, but I identify myself as just being, I just don't want anything to move apart, and I know that those heal. I'm not ever sure that the hinge heals. So that was your question. So this is a patient at 3 levels, significant disease, just like what Dr. Ahn said. Not much disease at 6, 7, but this 3, 4, 4, 5, 5, 6 disease process, soft, large disc herniation, straight canal, clearly myelopathic. I think we all agree, clearly surgery, further observation is not necessary. Sadly, we don't have the flexion extension films, but a pretty stable neck. Do you follow Sutton's law and go where the money is, go anteriorly, and would you give this patient as pretty advanced myelopathy, but no cord signal changes, the benefit of a hybrid ADR, maybe plus fusion, or would you do something posteriorly? Thank you.
Well, when I look at this case and I see the MRI, I see the compression anteriorly, I want to go where the money is. I want to go anterior. I mean, certainly you could do a laminectomy, but I think that, you'd have to do a very large laminectomy to feel comfortable that you've got good cord decompression. You're not going to do it at isolated level. So when I think about the invasiveness of the procedure, I like the anterior approach. If it's soft, I don't see why I wouldn't go anteriorly at those 2 levels. The problem is that what do you do at the non-affected level, the non-adjacent level? I'm not sure that this is congenital stenosis. This is real congenital stenosis. So, in these cases at the myelopathic level, I would probably choose a fusion. Okay, I think my preference there, I would feel more comfortable with it because it's so tight and it has congenital stenosis. However, if the canal is very large, I would also consider an arthroplasty at that level. I think in this case, which is kind of unique, I may actually arthroplasty the level in between. Although certainly it's not a part of the disease today, but if I'm going to fuse, I may have to include that in the fusion, and then I'm looking at a 3-level fusion, right? So, in some sense, I may actually consider fusing. I think it's a 3-4 level. Fusing, is it 4-5? Where's the non-adjacent?
The worst levels, I think, are 3, 4, 4, 5. Is that right?
3, 4, 5, 6.
And 5, 6. 3, 4, 4, 5, 5, 6. 5, 6 is really bad.
Okay. So, I think your options are you going to do 2 fusions at 3, 4, skip the 4, 5, and do a fusion at 5, 6? I think a lot of us would tend to fuse all 3 levels. And a 3-level fusion, it's not as easy to heal as 2 separate fusions, right? So I think I may even consider doing a 3-4 fusion, isolated, standalone, 5-6 fusion, isolated, standalone, and either leaving the non-adjacent level untreated or may place an arthroplasty at the middle level. I think those are kind of the options. But I would really hesitate these days in thinking that I would fuse 3 levels anteriorly. I would hate to fuse the middle level that really doesn't have disease.
Right.
So that's the problem. I think you could easily justify a fusion at the level that are myelopathic, but it's really the level in between. Are you going to fuse that? Are you going to do something else? Or are you going to leave it alone?
So thank you. So we'll have to move onwards, but maybe one more opinion. Maybe Terrence Kim, I saw you on the faculty board. Do you hear us? Can you give us your opinions? Okay, I'll come back to you later. Rick Sasso, I see you here. Rick, what are your thoughts?
Posterior cervical laminectomy infusion from C3 to C6. And after the decompression, we can obtain more lordosis and actually allow the cord to come back posteriorly to decompress it. And with a fused segment from C3 to C6, those anterior disc herniations and that anterior pathology will melt away over time.
That's a great point, the melting away of the anterior soft disc herniations. Dr. Ahn, you gave a very erudite perspective. What are your thoughts in terms of anterior versus posterior? We now have 2 diametrically opposed opinions. What are your thoughts? What did this patient get in your hands?
Yeah, my opinion would be even different from the other 2. So this is a great operation for laminoplasty. So if you do a 2-level fusion, intervening, we talked about, doing nothing versus, it's a big operation at the end of the day. And posterior laminectomy fusion, even a big operation. So this is a clinical impression, it's a myelopathy, right? So if you do a laminoplasty from C3 to C6, not 7, you're gonna take care of the myelopathy, you're preserving the motion. This is like one of the ideal cases for laminoplasty, in my opinion.
Can you just...
Problem is, the average laminoplasty loses 5 to 10 degrees of sagittal alignment over a decade. So if you're starting at neutral, you're going to end up with 5 to 10 degrees of kyphosis, and that's not going to be so good for the cord.
Well, you're talking about this. The patient is just, this is not fixed and neutral. Patient has a motion there. We don't have a flexion extension view. Patient could extend 25 degrees, flex 30 degrees. Patient has a functional spine. When you fuse from C3 to C6, you got the level that are fused. You can talk about ASD. It's just different opinion, but that would be my choice.
Hey, the easiest operation for the patient is anterior, any day. For a surgeon, if I said, Howard, I'm going to do a 2-level fusion for anterior or a posterior laminectomy, laminoplasty, are you going to tell me that you would choose the posterior approach for you?
So we have one way to resolve this. Next week, we'll have an audience response system. So we'll, as of next week, actually be able to poll our faculty and all participants. So we're looking forward to that. In the interest of time, Lincoln, can you show us what was done? And maybe Dr. Skuyan, who did the surgery, can explain what he did and why he did this. So Lincoln, what was done? It's quite evident. And how did she do?
Right. So we decided just based on the patient's imaging to do an ACDF studying from C3 to C6, of course, including the other one just because we were worried about adjacent level disease too. Not sure if this is seen, but other than that, we use a structural allograft, and actually the patient did very well after surgery. She was discharged next day with home therapy. I'm not sure if Dr. Skuyan wants to have a word about that.
Do we have the surgeon on camera here? Rod Skuyan was in early. He was the surgeon. Rod, do you want to tell us a little bit about why it was a fusion and not a laminoplasty?
So I think, it's interesting to hear both Dr. Ahn and Dr. Bay's perspective. I was worried about wound healing in this patient. So they were diabetic and not very mobile. And you saw the NURIC score in the neurologic exam. This patient was wheelchair bound and laying in bed a lot. So I thought, that he had a very high chance of having a wound complication post-op. So I chose to go anterior. And I do agree. I think there's some benefits into doing a laminoplasty. And also to Rick's point, to doing I think these are all great options. Cervical laminectomy infusion, I think he would have done fine. But I think I was worried about his neurologic condition and his inability to mobilize in his diabetes. So.
Isn't this what makes spine great? You know, you have all these smart guys with several hundred years of experience, and, you know, everybody can kind of justify what they are comfortable doing. You know, we don't really have data one way or the other. It's sort of an equipoise situation. So it's just a great discussion. I think it's a great teaching case. So thank you, Rod.
Sorry, quick question, just a number answer. Hyun, in a 3-level ACDF in a diabetic patient, systemically somewhat involved, what
Non-union rates using allograft, would you quote the patient? Lost again.
I think I heard you. I think I would use allograft. I'm just hesitant to use autograft.
What non-union rate? So what non-union rate, just as a percentage figure, would you quote the patient?
Oh, for 3 levels?
Yeah.
25%.
Dr. Ahn, more, higher or lower in Chicago?
I'm better than Hyun-Bae, so 10%.
All right. Eric Heyman is next with a variant on the same problem, but with a significant different slant. This is 10 years in the future.
Yes. So, hi, my name's Eric Heyman. I'm also a fellow here. I did neurosurgery training at University of Maryland, and I'm going to South Florida next year.
I want to give him this one because I just
to practice.
charged that.
The case I chose today was with the goal of inciting controversy, and after seeing the controversy generated by a relatively comparatively straightforward case, I'm looking forward to hearing the audience response. So briefly, the patient we're to discuss today is a 7-year-old male who presented to Dr. Schoon's clinic with axial neck pain and bilateral arm pain in primarily a C6 type distribution. He had failed conservative management, including medication, physical therapies, and injection. Of note, his history is significant for a right C3 to C5 anterior cervical fusion with a plate performed in 2000 by a different physician. Patient initially done quite well, but had been deteriorating over the past few years. Otherwise, despite his relatively older age, he's a very healthy, active, what I call a young 70-year-old. His past medical history is only significant for a couple of orthopedic type procedures. On exam, he had some residual hand intrinsic weakness from his previous bout of myelopathy, but it was otherwise full strength. Reflexes were globally diminished without any evidence of pathologic reflexes. CT imaging showed sort of the long-term sequelae of a fusion, or the potential long-term sequelae of fusion. I think this case really nicely illustrates what we talk about when we talk about fusion disease or adjacent segment disease. It's an insidious process. This patient presented 15 years later, but he's had essentially complete collapse and disruption of the adjacent segment at C5-6 with development of bilateral right greater than left foraminal stenosis and a concurrent radiculopathy. Like I mentioned before, he had failed conservative management, and his pain was quite disabling, so he was interested in pursuing surgical options. On flexion extension films, despite its apparent radiographic fusion and CT, the adjacent segment did demonstrate mobility less readily appreciated on the anterior aspect of the spine and more appreciated by movement between the spine's process, indicating that despite, again, this extensive, exuberant bone growth, that he has not fused at this level. Again, like Dr. Chapman alluded to, this is an expected complication of fusion and why there's such tremendous interest in motion preservation, whether it be in the form of laminoplasty, foraminotomy, or arthroplasty, is the idea of preventing these secondary surgeries as a result of the initial fusion. It's kind of an old classic paper, but Hillebrand first pointed this out, noting a 3% per annum incidence of adjacent segment disease in the decade after initial index ACDF, with a 25% incidence after 10 years, especially at the C5, 6, and C6 levels, which serve as the action segments of the cervical spine. So at this point, I'd like to go back to the imaging and just open the table up to discussion. Any thoughts on what you want to do for this?
Let's go from my top left leaderboard, Rick Sasso. So you had to be the second in line. This time you're number 1. Bad adjacent segment disease 5, 6, 6, 7. What do you do now?
So I'm a little confused. Does he have a C6 radiculopathy?
pretty clear clinical C6 radiculopathy.
Yeah, so I do a selective nerve sleeve injection. If that made all his pain go away, I would just address the C5-6 level from an anterior approach.
Okay. One vote for a single anterior approach.
Okay, let's see. Do we have somebody against that? So raise your hand. So Hyun, you were number one out of the box before. You talked about hybrid constructs. Is there any role for motion preservation? So Rick Sasso votes for a single level fusion, ignoring the 6-7 disease. Would you vote for a 2-level ADR just to be preemptive, even if 6-7 is not clinically symptomatic?
I think this one is tough because you've got to preserve the end plate to put a good arthroplasty in, and this is going to be very hard to preserve the end plate. I think honestly, if it's just an isolated level, and it's just C6 radiculopathy, I may think in this case going in the back and avoiding just a long fusion. I'm afraid of, I may just do a foraotomy for the guy. If we're not talking about stenosis and we're talking about just radiculopathy, why not? This is a great foraminotomy.
See head shaking. I see lots of head shaking.
All right.
I like.
Howard, are you shaking your head there right now? Or
I do a lot of foraminotomy, but foraminotomy, you cannot do bilateral foraminotomy and not fuse it. So if you're going to do foraminotomy, because you don't want to go anteriorly, you do bilateral foraminotomy, and then you have to fuse it. So when I do foraminotomy, it's a unilateral. And this patient has also a lot of neck pain, as well as bilateral C6 radiculopathy. So foraminotomy is not going to address the neck pain.
Well, if the patient has neck pain and we're trying to address the C6 radiculopathy bilaterally, then I would probably go in the back and just fuse it. I don't like a 4-level fusion. And now we're going to try to get a 4-level fusion for this guy from the front. I just don't like that. I don't like the
single level ACDF.
Are you saying you just decompress him from behind or do a fusion from behind?
Well, I didn't realize that the patient had a lot of neck pain. For a patient who has a lot of neck pain with this image, I think I would not want to do a 2-level ACDF on top of a 3-level fusion. I'm not sure what's level fused or how many levels are fused. Those things, in my hands, just don't heal that well. It's not just a single level ACDF. This is really that pseudo potential at the bottom of the construct. That's the same. It will be the same, right? I consider this more like a 3 or 4 level ACDF. I would probably, and if I was going to treat it like that, if I wanted to treat 2 disc levels, I'd probably go in the back and fuse it from the back. And this is a case where you're going to get a fusion.
Here, time is pressing. We need to go to LA and incite an LA controversy here with Terrence Kim and the great Patrick Johnson. So can you two weigh in? Is Dr. Hyunbae just off the rock, or can you disagree with him, or is he just speaking gold?
Can you hear me?
Yes, we can.
I absolutely love these cases. They're great.
So what do you want to do for this patient?
It's great controversy and
neck pain, bilateral C6 radiculopathy, or C7. I don't know.
C6. It's been isolated. It's been narrowed down.
I'm getting more aggressive all the time, and I would probably put 2-level artificial discs in this guy.
Whoa. Okay. So as of next week, we will have audience response system. Now let's ask one of the kings of disc replacement, Dr. Ziegler. You have some pretty big cojones. Is this in your bailiwick there to do an ADR on this patient?
No, I think it's a stiff spine. You got too many levels of bone on bone with very little motion preoperatively. So those are poor prognostic indicators for success after disc replacement. So I'd stay out of it, and I would just find the pain generator, find the root that's hurting them, and then decompress it and fuse it from behind would be my vote.
In the interest
is this guy 70?
I fuse it.
70.
So this guy is 70 years old. Okay, you've already screwed the pooch on that. Okay, Izzy, you're going to love this.
But leave him alone. He's wearing his Cowboys jersey. Leave him alone.
Well, no. I think they screwed the pooch on this straight ACDF, where you've created this deformity where it's not his last operation. So it's maybe it is because he's 70, I agree with Jack and some of the guys have said just treat the level that's symptomatic right now, and obviously you hope he lives long enough, but if he's got another problem in the future, you treat it in the future, because you're not going to solve this problem. I mean, if you want to solve this problem, you got to go above, you got to go 2 levels below and recreate his cervical lordosis. If it's just a C6 radiculopathy with some neck pain, I agree, just treat the 1 level like Jack said.
And to take what Bay said, I'd much rather go anteriorly than posteriorly. If you're going to
I would say anterior also, yeah.
So Howard, closing the loop to laminoplasty, do you see these kind of fusion disease patients long-term with laminoplasties? I showed you a patient of mine, a vascular surgeon who has significant disc decay, but I so far have not had to reoperate him. He's like 14, 15 years out now. So does this kind of a disease propagation happen with laminoplasties? How often do you have to reoperate your cases? I think we lost Howard right now. Let's go to Eric. Why don't you resolve the case, and then maybe Dr. Ahn will be live again.
Okay, perfect. So as I suspected, there's a lot of controversy, ranging from treating the symptomatic level either focally with a foraminotomy or an ACDF and hoping to run out the clock, so to speak, before the next several of days. Some people propose treating both levels, and then there's fuse the whole neck and, correct the deformity and do a definitive operation, all which are valid with good reasoning. One response I heard, which surprised me a little bit, was the 2-level arthroplasty. Just because arthroplasty, at least where I was taught back home, it can be considered contraindication for such extensive fused disease. And this was kind of a learning case for me. Certainly because what we did was an arthroplasty. I think the flexion extension, careful review does show that there's mobility at this level. And intraoperatively, we found that, after we sort of released, some of the anterior ligaments and the uncovertebral joints, we were able to expand the disc space and get an arthroplasty in there with minimal drilling or, disruption of the end plates. The patient did great. He went home the next day, and 6 weeks out, he reports being pain-free without recurrence of the symptoms. Whether we got lucky or whether that this is, a better way to treat these kind of controversial cases, where you're worried about adjacent segment, you don't want to fuse the whole spine, I think is an area of controversy, which is reflected in the literature, where there are case series of using arthroplasty for these kind of adjacent segment diseases, but at least in my search, I couldn't find, large, high-quality studies reflecting that.
Can you go back to the images?
Hey, I like it. I like it. After seeing it, I want to change my mind. I like it.
Listen, I'm a little embarrassed that our TBI boys that we didn't say to go ahead with an arthroplasty.
No, I like it. But you know what I like also is when you look at that neutral film. I mean, I think you actually gave this guy some extension. Like I think you gave this guy functional extension, which is interesting.
I mean, again, I think if you were going to do an arthroplasty, the prosthesis you chose was the correct prosthesis. But I think it'll be an equivalent result to an ACDF. But obviously, the guy's got more global issues, but I can't argue with the solution.
As I said before, isn't spine great?
So Rod,
very clear cut.
So let's ask the surgeon to
a lot of gray.
Why he chose something that nobody else had suggested. He chose a single level ADR. We heard 2-level ADRs, but Rod, can you tell us what your thoughts were on this patient?
Yeah, so, after listening to the Texas Bat Guys for the last 10 years, I remember actually talking to Dr. Ziegler in the lab at SSF, and he was telling me about how this is the best indication to do arthroplasty, and a lot of times when you do flexion extension, you have to look at the spinous cross-section, and you get great indirect decompression. And it's great for people who have bilateral foraminal disease. And so, honestly, I wouldn't have thought about it if it wasn't for Rick Geyer, Scott, and Jack just over the years kind of pounding into us that an arthroplasty is a great operation. And Hoon actually came up recently as well. And I think, what's interesting to me, the difficulty's been, I'm going back now to using constrained devices on these adjacent rather than unconstrained, because I do think that the device that you use makes a huge difference. And so, I think to me, this was a great kind of a in between, doing a big surgery and doing a foraminotomy. I think that was kind of but the difficulty for me was deciding on the actual device. And so I used a Pro Disc in this case.
I totally agree. And when you get your Texas license, come on down.
Yeah, listen.
So yeah, I think what's amazing is that patient doesn't need a collar. You've avoided another fusion. You've given him what looks like to be some lordosis. You certainly hasn't decreased it. I mean, yeah, I think functionally you did the patient a favor.
Mm-hmm.
I have to chime in here from Los Angeles because, I think that there's a lot of great points here. And Bay, I agree with you, is that you do anterior cervical. It's a pretty painless operation. The patient gets his radiculopathy treated. It's interesting. I would bet you that among all of us, we might have just a great collection of anecdotal cases that are maybe a really good contribution, because I'm thinking back right now, just this week, I saw a patient very, very similar to this. I did a single level. The guy's he says he's 100%, which I'm not sure if I believe him, but then I think back to a couple other patients. One came from Eastern Washington. I'm sorry, you guys, but he came down to LA to see me. And he had a fracture many, many years ago and had a 3-level fusion from T1 upward. And we put in 2 artificial discs, and the guy's so happy. It's amazing, So some of these adjacent segment things that stopping the adjacent segment degenerative changes that we know are going to happen. I mean, we got to stop fusing people first time, and then we got to try and stop these things with cases like this. I mean, and the only way you can find out, I think, is do them. Okay, that's the way we get experience. Is it a wrong operation? I don't think it's a wrong operation. What if it didn't work and the guy has to have a fusion? I mean, you can always go back and do it. But, the older guys, they got hard end plates. It's not like the lumbar spine in young female, or old female patients that are going to have osteoporosis, is that you can load the end plates in these and the disc will survive. So there's lots of reasons why these things make sense. And, trying to stop that fusion disease from adjacent segments is it's one of my mantras. Great case. Great case.
Yeah.
So we'll have to close. We ran a little bit over. My apologies. May I ask one of our TBI colleagues who are hosting it and originated this to give us some closing words?
Scott, want to do it?
Well, thank you. I mean, I think this was tremendous. Jens and your fellows, you did a great job. To have all these respected colleagues from all over the country, I think we're changing the way education is going to be done from now on. And I hope even after the Armageddon, we continue these things. It's incredible, and it's just going to grow. So thank you, guys.
Thank you very much, guys. Thank you.
Thank you.
Seattle Science Foundation.
All right, guys.
See you next week.
Congratulations.
Take care.
See you next week.
Jens, Rod, Linda, great job. Alexis, great job. Love you all.
Thank you.
Great to see you. Hey, guys, take care. Bye-bye.
Thank you. Thank you.
Thanks for watching. Hit the subscribe button for more medical content.